Hope you enjoyed the day so far and you managed to catch up with your coffee and the chat and get some more calories in. So this talk is about the first trimester skeletal dysplasia, what's possible in 2025. And skeletal anomalies, they tend to be quite challenging, is it? It's a not easy thing to handle. So let's do it again like what we did earlier. We're going to start with a quiz. And if you answer all the questions correctly, maybe you don't need the lecture. Okay, so 20 weeks fetus, the femur length is below the 4 standard deviation. There is severe bowing, and there is reduced skull mineralization, and there is multiple rib fractures. What is the most likely diagnosis? See, osteogenesis imperfecta type 2. Easy? Fantastic, good. I'm going to go home now. Okay, what measurement is most predictive of lethality in skeletal dysplasia? B, easy, thoracic circumference over the abdominal circumference ratio. Good, doing well. A fetus at 30 weeks have normal skull mineralization, there is frontal bossing, there is rhizomelia, trident hands. What diagnosis is most likely? A, everyone on the same page? Achondroplasia? Correct, okay. And if we have time, or maybe tomorrow, we've got cases, so I've got sort of, I can show you some of the images and clips from cases of achondroplasia diagnosis in the third trimester. Often it's a diagnosis in the third trimester. First trimester clues to skeletal dysplasia include all except early micromelia, narrowthorax, polyhydramnias, bone demineralization. See, because you never get the polyhydramnias in the first trimester, yeah? You always get it later. Which skeletal dysplasia is most associated with a clover leaf skull? See, it's an anaphoric dysplasia type 2. I think you're doing well. I think we should go home. There's the problem with the people outside, the people who are chatting. I think we should bring them here. Okay, so again, similar to what I showed you in the talk earlier, we're going to start with sort of the basics, and then we build up to get to see more of the complicated stuff. But if we start with the embryology, with the development, and if you look at the limb bud development, if you see at 5 weeks, they start at just the out buckets from the frontolateral body wall, and by 6 weeks, you start seeing the circular constriction, which will be the future wrist and the ankle creases. And by 8 weeks, you should be able to see the limbs in their definitive forms, the 3 segments. So at what gestation should you expect things to see? So you should see the limb buds by 8 weeks. You should be able to see the femur and the humerus by 9 weeks. You should see the tibia, fibula, radius, and ulna by 10 weeks. You should be able to see the digits of the hands and the feet by 11 weeks, and the body movements already demonstrated on ultrasound scan by 9 weeks. Okay, so we are in the era of the NIBT, and therefore we're doing more and more scans at 10 weeks when this patient comes for the NIBT. So how do these limbs look like at the 10-week scan? Do they look the same at 12 weeks? And the answer is no. So at 10 weeks, they often straight, so the lower limbs, they tend to be straight and short. This is at 7 weeks. By 8 weeks, again, they're still straight and short. And here, 9 weeks and 6 days, they almost like a frog-like position, so they're close proximity, the feet touch each other. And again, here at 10 weeks, the same. So I call it a bit like frog-like position. What about the upper limbs? So the upper limbs is like this. They close to the anterior chest wall, and they often, again, so that the hands is very close to the anterior chest wall. And certainly the first trimester, not at 10 weeks, but from 11 weeks onwards, is a really golden opportunity to be able to look at the fingers, because the baby cannot close the hands. They cannot have a fist. So often, always the hands are open, and it's really with good resolution, particularly with a transvaginal, you can easily count the 5 fingers. It's really useful for limbs in the first trimester, yes, sometimes, and we've seen sort of beautiful images, but actually still, I don't think it needs to be the primary form of or method of diagnosis. Still, we make the diagnosis in 99% of the cases using 2D ultrasound. So what do guidelines expect us or recommend? So what's expected from everyone doing first trimester ultrasound scan. So this was the first trimester ultrasound that was like published before, or the first version. And here you see the extremities. You need to demonstrate that there are 4 limbs, each with 3 segments, and that the fact that the hands and the feet have normal orientation. That's what was expected before. We mentioned earlier that the ISWAG updated their first trimester guideline. It's published a couple of years ago now, and now they have the minimum requirements, so that's for everyone, and there is a bit more advanced or more detailed. For the minimum requirement, the same, the 4 limbs, each with the 3 segments, and the more advanced or the more detailed, the fact that you also, the three segments in the 4 limbs and the free movements. Do we measure the femur? We had a discussion earlier about what biometry should be performed in the first trimester. And if you would measure it, you measure it again the same, so long axis, you put the calipers at the either end of the ossified diaphysis. And there are, of course, some advantage of measuring, is it? Because if you measure something, it means that you definitely looked for it. And therefore, your ability to identify skeletal abnormalities, particularly severe skeletal dysplasias in the first trimester, is likely to be better compared to just doing nucal and the crown rumblings. Having said that, it is not recommended in any guideline that we should routinely measure the long bones in the first trimester. So that's about the ISWAG guideline. Another relevant guideline also about the first trimester that I was involved in is the WABM, the World Association of Perinatal Medicine. And they also had sort of this similar approach, is what's sort of the basic and what was a little bit more advanced. And again, if you look at the recommended in all the scans, that you should demonstrate the 3 segments, so the upper leg, the lower leg, and the foot. The same for the arm, upper arm, lower arm, and the hand. And the fact that there are bones, so you're looking at there is 1 long bone in the upper arm or the upper leg, and the 2 long bones in the lower leg on the lower arm. And if you do that, and the regular proportion, and I'm going to show you how short long bones look like in the first trimester, but if you do that, you should be able to identify some abnormalities like limb reduction defects, which is the commonest skeletal anomalies in the first trimester, or things like skeletal dysplasias, where they tend to have very short long bones in the first trimester. Also, in terms of the hands and the feet, so they expected that you demonstrate the hands and the feet. And you can do that either in the axial or the sagittal planes. And again, that means you can be able to identify limb reduction defects. Also commenting on the movements. And the movements in terms of the baby's extending and the flexing the joints. And that means you could identify the things like neuromuscular anomalies or fetal akinesia deformation sequence. And I'm going to show you some examples later. So can we see arthrogryposis in the first trimester? And the answer is yes. This is a case that was referred to me. And you can see here the arthrogryposis by definition is malposition of the limbs with limited movements, and they can cause contraction that affect 2 or more joints. And arthrogryposis either could be regional, so only affects maybe the upper limbs or maybe just the lower limbs, or it could be generalized, affecting the 4 limbs, and when it's generalized, that's what we call the fetal akinesia deformation sequence. So how do they look like? Well, characteristically, in arthrogryposis, the lower limbs are extended and usually crossed, and the upper limbs are usually flexed and closed on each side of the thorax. Once you have this arthrogryposis, and you see here the images, you see the lower limbs are extended here, and again with limited movements, you really need to do detailed ultrasound looking for other systems. In particular, you should look at the profile, looking for the micrognathia. Most of these cases, whether the arthrogryposis or other form of skeletal abnormalities, particularly skeletal dysplasia, very common finding is the increased nucal translucency. And then you look at other things like the narrow chest, which often will give you a clue about the lethality. And the body hydramnios, you never see it in the first trimester. You only see it really in the 3rd trimester after 25 weeks. So once you have this case of fetal arthrogryposis, what should I do? What additional test, or what should I look, apart from actually doing detailed ultrasound looking for associated abnormalities? You need to offer genetic testing because they can be associated with chromosomal abnormalities, particularly trisomy 18 and 8. And there is a long list of genetic syndromes that they can be associated with. I put here some examples, and I just wanted to highlight this autosomal recessive nature of inheritance. And therefore, two messages. Number one, make sure you involve a geneticist, because you will not remember and you will not be able to rule out all of these genetic syndromes. But number two, try your best to reach a diagnosis because of this autosomal recessive inheritance, which means a higher chance of recurrence of about 1 in 4. So don't miss this opportunity and just offer termination of the pregnancy without an attempt to actually reach diagnosis because of the risk of recurrence. I mentioned earlier that the first trimester is a really golden opportunity. If you have the baby in a good position or the patient slim or you're doing transvaginal ultrasound scan, you can easily get these beautiful images demonstrating all the 5 fingers and even the toes. I mean, maybe a little bit harder, but still you'll be able to see that. And I think we saw earlier Simon talking about the clues of having polydactyly, for example, that the foot from the front is broad compared to the back of the foot. And again, also in terms of the position of the hand in relation to the rest of the limb. So this is a very famous slide, is it? What abnormalities are always detected, what abnormalities are sometimes detected. And this is a list of the abnormalities or major defects that should always be detected. So if I miss any of them, I'll feel bad because I should really have picked up acrania, holoprosencephaly, exomphalus, gastroschisis, megacystis, body stalk anomalies if I follow the protocol. But what about skeletal anomalies? Are they actually always detected? And the answer is no. In fact, if you look at the detection of hand and feet abnormalities in the first trimester, even absent hands and feet, the detection rate in the first trimester is only about 60%. So even when I say the guidelines say that we need to demonstrate the hands and the feet, it's still missed in about 40% of the cases in the first trimester. So why skeletal dysplasia or skeletal abnormalities are difficult or challenging in terms of the prenatal diagnosis? For a number of reasons. They tend to be rare. Most of the people will only come across few of sort of the different syndromes. And even in the literature, there are few case reports. It's not like something like Down syndrome where there's plenty of cases and plenty of experience. It's often actually, you cannot reach the final diagnosis using ultrasound only. You need to do additional tests, particularly genetic testing, particularly now exome genetic testing. Sometimes there are incidental findings, like things like polydactyly. And they're very, very important having this systematic approach. You need to have really, once you suspect it, you need to go to the right side and be really systematic or having a protocol. So the limbs, it's not enough to say there's a short femur or short long bone. You need to assess the length, you need to measure all the limbs, you need to comment on the shape. Are they straight, are they bowed, are they bent? You need to comment on the mineralization of these bones. You need also to comment on the movements of the joints. And then there are other systems, that's not skeletal, that commonly link to skeletal abnormalities. And if you find abnormalities in the system, can help you with the diagnosis, particularly the head. So for example, a lot of skeletal dysplasia will have big head, microcephaly, or they have a frontal bossing or abnormal face. The thorax, because it helps you to assess the lethality. Is it likely to be lethal or non-lethal? To look at the spinal abnormalities. And then associated abnormalities, particularly the heart and the kidneys. So we are in the era of the exome genetic testing and whether we should be offering exome to all these cases or not, well, it depends on the additional yield. So if I do the exome genetic testing, how would I be able to diagnose things more compared to the traditional array? And actually, the studies are relatively consistent, that there is additional diagnostic yield in about 70% of the cases. In fact, this is probably the system, the skeletal abnormalities, with the highest diagnostic yield from the exome. And in fact, if you have isolated short long bones, in this study, the incremental diagnostic yield above or over the array was about 67%. And if you have non-isolated cases that you have associated abnormalities, is nearly 80%. And that's consistent. Many studies and even systematic reviews also quote this high yield. And the one in this study, the feature that had the highest additional diagnostic yield was if you have abnormal skull, or if you have small chest. So, and therefore, if you suspect the skeletal dysplasia or you have skeletal abnormalities, and I'm not talking about polydactyly isolated, I'm talking about short, long bones, particularly with associated abnormalities, definitely offer genetic testing, definitely involve a geneticist, and offer exome, and offer it early. Don't wait to do the PCR and then array, and then think about the exome. So in my practice, we would involve the geneticist and order the exome from the beginning. So how do the short, long bones look like in the first trimester? And I showed you this, and this is the video. And the reason I showed you, because they really look like dots. They're very, very small, like almost echogenic dots. And I think it's really important for you to actually see, because you only identify what you're aware of or what you've seen before. If it's something you've never seen it, you will miss it. Okay, so once you see it, you said we should measure it. And do we have reference ranges for the short, long bones in the first trimester? And the answer is yes. And I put one of these examples in the reference. And you see the female length here between 11 and 14 weeks. And this is the reference range. Okay, the second thing is about the mineralization. And in the first trimester, if you have high-bow mineralization, there's only 3 conditions: achondrogenesis, hypophosphatasia, osteogenesis imperfecta. But there are 2 important messages. Number 1, where should I see the hypomineralization? And one of the best places is the skull. So you'll be able to see the brain or the choroid plexus or the butterfly appearance more easily than what you expect. So that's a good place to look at the mineralization. The other thing is that osteogenesis imperfecta, they can really vary in terms of their presentation, from really severe, like type 2, to very mild, subtle features like type 1. So not all cases of osteogenesis imperfecta will have hypomineralization that is easily detectable on the scan. And if you see it in the first trimester, it's likely to be one of the more severe, like type 2. What about sirenomelia or mermaid syndrome? If you see a case, you will never forget it because it's very unique. So you have single lower limb, and they tend to have associated abnormalities, particularly bilateral renal genesis and single umbilical artery. They tend to have genital anomalies, have oligohydramnias, and certainly much easier to diagnose in the first trimester than the second trimester. And you think about the differential diagnosis, particularly caudal regression syndrome, they're often not associated with genetic abnormalities, so you don't need to offer genetic testing. The usual is sporadic, but they can be associated with diabetes. So ask about the maternal history of diabetes, and fortunately have low risk of recurrence. Again, this is the ultrasound image in the first trimester, and you can see here, you see the 2 femur, and then single lower limb, almost fused. And again, another case here. So not a good quality scan, but you can see there's 1 single lower limb, and this is a post-mortem picture. So what's the most common abnormality, skeletal abnormality detected in the first trimester? And I mentioned earlier, it was a limb reduction defects. So, and therefore, let's be familiar with the terminology of limb reduction defects. So amelia means complete absence of the limb, and you can see the images there. Achiaria or acharia, which is absence of the hand, and that can be the amputation of this upper extremity is usually an isolated, so if you have the upper arm or the upper limbs, often isolated, but actually if you have it in the lower limbs, particularly if it's bilateral, be careful, it could be part of a genetic syndrome. So what examples of genetic syndromes that are associated with limb reduction defects or amputation you can see here, like aglossia, adactyla syndrome, or Mobius syndrome, so be again familiar with them. And 50% of them are multiple, and a quarter of them have associated abnormalities. But be very careful of the amniotic band syndrome. So sometimes the cause is this amniotic band syndrome, which is sometimes very difficult to actually demonstrate on the ultrasound, and I'm going to show you an example. When it comes to the amniotic band syndrome, commonly, we think about looking at the digits, looking at the toes, looking at the extremities, but actually also sometimes limb reduction or amniotic band syndrome can affect the craniofacial region and can cause large facial defects or clefts. But also they can affect the umbilical cord, and therefore they have higher risk of intrauterine demise. So if you have a case of amniotic band syndrome, monitor this pregnancy carefully to make sure that the umbilical blood flow is normal. So I mentioned earlier the amniotic band syndrome, sometimes they're really, really tiny. They're very thin, and it's very difficult to identify. And that's why Simon earlier said put the gain up to try to see the band. And therefore, often we diagnose it or suspect it when we look at the effect of the amniotic band. So for example, if you have absent digits or portions of the limbs, or actually that you have a swollen foot, for example, or a swollen hat, because the very tight constriction by the band will impair the venous flow, the venous return, leading to the swollen foot, for example, or swollen distal limb, before ultimately it causes ischemia and amputation. And therefore, sometimes you will see the swollen, and I give you the clue that there is amniotic band syndrome. So this is a case that actually was referred to us in the first trimester. You can see there's 13 weeks. And they refer because there was absent digits or portion, absent digits and swollen distal, I think the swollen foot. So now I'm going to show you this case. So 13 weeks, you could see that there is maybe absent digits, but and maybe here, so you can see this membranes there, and maybe there is a band, and we scan trans-abdominally and trans-vaginally. By 16 weeks, definitely there's some missing digits, but here you see this foot. So it's very swollen, and there is definitely, when you put the color Doppler, there is reduced blood flow. And here, 17 weeks, the swollen foot is getting worse, and here with the 3D, you see the missing digits. So the parents were very committed. In the UK, of course, there is the option of stopping the pregnancy or termination, but these parents wanted everything done for the baby. So they were really committed, and they didn't want the baby to lose the foot, because certainly, if you carry on like that, it's very likely they will end up by amputation of this foot. So they wanted everything done, so we decided to do endoscopic excision of the amniotic band. And this was actually filmed as part of the documentary Baby Surgeons Delivering Miracles, which was on Channel 4 in the UK. But you see, when you do the fetoscopy, the visibility is not great because you have a lot of these bits of membranes. Amniotic band often have lots of these bits of membranes. So the visibility is usually not great. But you can see here, this is the band. And the band is usually very, very tight. So when you're trying to actually cut the band, you have this special scissors which has a hook to actually try to detach the tight band. Anyway, so it was done, it was good, we saved the foot. The baby was born at about 32, 33 weeks, and the baby's doing well. So again, just to summarize about amniotic band syndrome, because it is one of the causes of limb reduction defects you need to be aware of. And as I said, it's not always just missing digits and or limbs. It could actually affect also the body and can cause facial cleft. And the most extreme, it can be the body stalk anomaly, like what I told you in the earlier talk, which is this amniotic rupture sequence. So again, just to reiterate, it can affect all sorts of things. Commonly, it will be the distal part, the digits, but also can affect the other parts and can cause intrauterine demise if it goes around the umbilical cord. The other thing with limb reduction defects is that make sure you take a proper history about the drugs, about the medication that this patient is taking. And this is just a useful table if you want to take a picture of the potential drugs and their maybe effect on the skeletal system. And of course, things like cocaine, like alcohol, and other sort of drugs that are known to be teratogenic. But also, I think I found that useful in another scenario, because sometimes patients get pregnant, and for example, they were taking vitamin A, or they were taking other medication, valproate, and they come to you because you're the fetal medicine expert, that you would look and to do detailed ultrasound scan to see whether this baby has been affected or not. So it's important to know what you're looking for. Okay, what about phocomelia, and obviously the history again of sort of the drug use in pregnancy, or they call the seal limp. And nowadays, yes, we don't give this antiemetic in pregnancy, but be careful of the association with genetic syndromes and be aware of this particular 3, Rupert syndrome, which they tend to be autosomal recessive, and they tend to have facial cleft, and it can affect the 4 limbs. The TAR syndrome with thrombocytopenia absent radius, and the Grip syndrome, again, autosomal recessive, and they have very, very short, the upper and lower limbs, but the lower limb is more affected than the upper limbs. This is a Grip syndrome, as I mentioned, autosomal recessive, and you can see here very, very short, but the lower limbs tend to be more affected than the upper extremities. And here on the ultrasound scan, you can see it at 10 weeks. Remember, I told you at 10 weeks, the lower limbs should be like close to each other and the feet almost touching each other, a bit like the frog-like position. Here, they're short and they're widely separated lower limbs. What about club hands? And the club hand could be radial or ulnar, depending on which long bone is affected, whether the radius is affected or the ulna is affected. The radial club hand is often associated with other causes or genetic conditions, so that the radial aplasia, and therefore the hand is deviated in this side, and they can have absent or hypoplastic thumb, while the ulnar hand may be deviation on the ulnar side, and they can be complete absence of the ulna, and often not associated with genetic conditions, usually isolated, the ulnar club hand, compared to the radial club hand, which is frequently associated or frequently syndromic, particularly with trisomy 18, but you're not going to miss trisomy 18 because they tend to have lots of other abnormalities. But be careful of the other things, like the thrombocytopenia absent radius, or Holt-Oram syndrome. And in this one, look at the heart, because they tend to have heart abnormalities. Roberts syndrome, they tend to have facial cleft. Also, they can have heart abnormalities, and they can have phocomelia. And of course, sometimes you only have vectors. So you do the genetic testing, and you don't find any genetic abnormality, but you look at the association between different systems affected. So the TAR, and this is again sort of images, nice, beautiful images from Simon, and you see here the ulna, the radius is absent. This is a radial club hand, and here this is the 3D image, and you see the hand is deviated radially. This is the hand, and there is only one bone, which is the ulna, and again this is a picture. And of course, if you have a case of thrombocytopenia absent radius, think of the differential diagnosis like Fanconi and Holt-Oram, and Holt-Oram tend to have heart abnormalities, while TAR is not usually associated with cardiac anomalies. So this is a list of the differential diagnosis. Fanconi anemia, yes, they have absent thumb. Holt-Oram, heart abnormalities. Cornelia de Lange, you really need to be careful. So sometimes you come across it with babies who are small for gestational age. So when you have a small baby that you're seeing for the first time or you're following up, don't just think it's a small baby, constitutional or placenta insufficiency. Think of genetic abnormalities, particularly when the Dopplers are completely normal. So Cornelia de Lange, they can have facial abnormalities, and again, they can sometimes have heart abnormalities, not severe. The Neger syndrome, they have mandibular hypoplasia and malformed ear, trisomy 18 and 13. Number one, you're not going to miss it. But number two, in the era of NIBT, often majority of trisomies are diagnosed in the first trimester even, so they don't even get to the second trimester. I mentioned about the Vater association, which is almost diagnosis by exclusion after you've done the genetic testing, and Roberts syndrome, which as I mentioned earlier. What about polydactyly? Very relatively common. Depends how you describe the polydactyly. So either pre-axial or post-axial. The post-axial is on that side, next to the little thumb, while the pre-axial next to the thumb. And the post-axial, often isolated, they tend to be autosomal dominant. So often I ask the family history, and they said, yes, actually the father had post-axial, already born with polydactyly. It runs in the family, more in Afro-Caribbeans, while the post-axial tend to be syndromic and can be autosomal recessive, and particularly if you see it in white people. And the polydactyly could be actually a whole finger, for example, with the bones, or it could be just a soft tissue, so like fleshy nappen, or complete digit. Also, you can have the post-axial, more common, often isolated. The pre-axial, be careful, they could be syndromic, but also rarely you can have central polydactyly. So that there's an additional finger between the middle and the ring finger. Often bilateral, often associated with other abnormalities, and tend to be autosomal dominant. So be careful when you have polydactyly, look for associated abnormalities, and be careful of this list of associated genetic syndromes. Many of them would be skeletal dysplasia, like short rib polydactyly, Ellis-Van Grevel syndrome, but also other things which are not part of skeletal dysplasia, like Meckel-Gruber. So whenever you have polydactyly, straight away look at the kidneys, especially in the first trimester, and look for occipital encephalocele. That's for the macrogrouper. For bradipedal, sometimes they have very subtle, really subtle, only polydactyly and maybe kidneys, but sometimes the kidneys are not very clear, very obvious in the first trimester. So bradipedal sometimes can be tricky to diagnose in the first trimester. This is a case of macrogrouper, and you can see here the polydactyly. You see here the occipital encephalocele. You see here the bilateral cystic kidneys, and here this is the abnormal gene variant that is caused, or heterozygous pathogenic variant in this gene. The opposite to polydactyly is oligodactyly. You have fewer number of digits, and again, it can be associated or linked with associated abnormalities and syndromes. So do detailed ultrasound scan, and if you have associated abnormalities, offer genetic testing. Syndactyly, which is the fusion of the fingers, and the fusion can be complete, so all the way. It could be incomplete, so only part of the digits. It could be a bit complex, or it could be complicated. So syndactyly, I think, is not easy to be picked up. It needs to be really someone who's good and looking systematically, meticulously. Often missed, I would say. Syndactyly, mostly isolated, but they can be associated with chromosomal and genetic syndrome, as you see in this list. But genetic syndromes, often they will have a lot of other associated abnormalities as well. The other thing is the ectrodactyly. And the ectrodactyly, if you see one case, you will never forget. The other name is the claw deformity, because if you see and it can affect the upper limbs or the lower limbs, because it does look like a claw. The other terminology is EE syndrome, ectrodactyly, ectodermal dysplasia, cleft syndrome, or split hand, or split foot syndrome. So I said, like, if you see it once, you will never forget it because it's very characteristic. They tend to be autosomal dominant, so they might be family history. It affects the four extremities, the both hands and both feet. They're more severe deformities in the hands and the feet. They can have facial clefts, so go and look carefully on the face. And they can have also ectodermal defects, which you're not going to be able to diagnose prenatally. Other limb abnormality, which are markers of chromosomal abnormalities, things like Lasandel gap, which is obviously associated with trisomy 21, and clinched head, which are associated with trisomy 18. But as I mentioned, in the era of NIBT, which a lot of these cases are picked up in the first trimester, you don't really see these cases in the second trimester unless they didn't have first trimester screening, for example. Clinodactyly, which is, again, sort of, you see medial deviation or radial curvature of the finger, of the fifth finger, and often affect the distal interphalangeal joint. And as it can be isolated, so it's not always trisomy 21. It could be just completely isolated, benign, and they can be bilateral. Okay, so this is an interesting case where in the first trimester there was just a ducted thumb. That was the only thing. There was no other abnormalities. And it wasn't until this 18 weeks or in the second trimester where you also saw the bilateral ventriculomegaly, and this case had genetic testing, exome, and had L1 CAM. So again, reiterate that when you see this patient, you need to keep monitoring, and every scan is a detailed scan. So don't just say, well, it was just a ducted thumb. You need to also look for progression, because some of these abnormalities will not be obvious in the first trimester. And we had the discussion earlier in the last session about whether the first trimester scan would replace the second trimester scan. I don't think so, because there are features, abnormalities, particularly the brain, that actually will only be apparent after, later in pregnancy. Talibus, you can see it in the first trimester, but commonly you don't see it. So most of the cases of talibus are only picked up in the second trimester. They're not really seen. So if you see normal ankles in the first trimester, does not rule out later appearance or diagnosis of talibus. The fatal akinesia deformation sequence, as I mentioned, they tend to affect all the limbs, so the four limbs, and they have a problem with the joints or the movements, and they can have polyhydramnios, often diagnosed for the first time after 25 weeks or in the third trimester because the problem of the swallowing, and they can be associated with genetic syndromes. I'm going to finish my talk by talking about skeletal dysplasia in the first trimester, because they didn't really used to be commonly or diagnosed or picked up in the first trimester. And this is an article that I published in Literature years ago, back in 2011, where actually we were looking at the cases of skeletal dysplasia and looking at what was the features, ultrasound features in the first trimester. And this is a list of these skeletal dysplasias. And what I found when I studied all of these cases individually, one of the commonest findings was thickened nuchal translucency. So if you have thick nuchal, it's not enough just to do Down syndrome and do genetic testing. Look and do detailed ultrasound scan. The femur can be short, bowed, broken, absent. So you need to bother to look carefully and know what you look for and what's the appearance in the first trimester. The arms and the legs, they tend to be short and they can have abnormal shape, and sometimes they are asymmetrical. So it's not always symmetrical. The thorax can be small, narrow, or short ribs or broken hips. And this is the appearance of the narrow or small chest in the first trimester. You have this bell-shaped chest that you can demonstrate in the coronal view. And as I mentioned earlier, the skull, the mineralization, and to look carefully and have systematic examination of the baby. The hands, you can have all of the things that I mentioned earlier, polydactyly, oligodactyly, you can have the hitchhiker syndrome and dystrophic, I'm going to show it to you later. You can have absent radius, club hands, cleft hands, so all of the abnormalities that I mentioned, it could be affecting the hands or the feet, and again, you can have spine abnormalities. So let's just go through some of this skeletal dysplasia and shows you what the features in the first trimester scan. So this is a case of actually was IVF pregnancy, and she came at the 12 weeks, had an RBT that was normal, and this was the femur, and this was the appearance, and this was the chest, and you can see there was short femur, radius, ulna, abnormal hand, abnormal feet, and you can see this is the reference charts, and it was osteogenesis imperfecta type 2, which is very severe, and she had termination of the pregnancy. So cases here of osteogenesis imperfecta, and this is the appearance of the broken ribs, and you can see that in the first trimester at 13 weeks plus 5 days. Also, you can have short rib polydactyly, where the ribs are very, very short, as you can see this picture, compared to what I showed you earlier in my talk about the anterior abdominal wall defect. This is the appearance of the small chest early in pregnancy, the bell-shaped chest. The hitchhiker that I mentioned to you earlier, which is the synatophoric dysplasia. You can have frontal bossing, which can sometimes be identified late in the first trimester, 13, 14 weeks, or abnormal skull shape. Synatophoric dysplasia, which is mutation in the FGFR3, which is the commonest lethal skeletal dysplasia, and therefore have very low risk of recurrence because it's lethal by definition. And the cases should be you should be able to diagnose it in the first trimester. For osteogenesis imperfecta, apart from the hypomineralization and the bent long bones and the fact that they can have abnormal position of the hands and the feet, these cases, they tend to be 4 types of OI from 1 to 4, and they result from a mutation in the COL1A1 or COL1A2 genes, and these 2 genes, they code for the collagen. And of course, we know that the collagen is a major component of the bone matrix, hence explains the ultrasound features that you see in terms of the hypomineralization and the bones being easily bent and fractured. This is the hitchhiker in dystrophic dysplasia. So if you see short, long bones, and if you see this appearance of the arm, of the hand, hitchhiker, that really helps you in terms of the diagnosis of the dystrophic dysplasia. Short lip polydactyly and Ellis van Greveld, again, they tend to have short, long bones. They tend to have polydactyly, so be careful and look at the fingers carefully, and they can have also renal abnormalities. Campomelic dysplasia, which is another form of skeletal dysplasia that's secondary to the SOX9 gene mutation. They do have short bowed femur. The features tend to be worse in the lower limbs than the upper limbs, so they can have straight humerus but bent or bowed femur. And characteristically, if you look at the scapula, the scapula tend to be hypoplastic, so very small, or absent. Compare, I put here, this is an appearance of normal scapula compared to hypoplastic scapula, and they can have discrepancy in the fetal sex or gender between the appearance on the ultrasound scan and when you do the genetic testing. So the genetic testing could be XY, but actually the appearance on the ultrasound is female. So I'm going to stop here. I hope that I give you a quick overview of skeletal abnormalities in the first trimester. You can see there's a lot to cover, and it's often, again, complex, but the key really message is make sure that you have the knowledge, that you have the skills to do the detailed ultrasound scan, and involve the geneticist. Thank you very much for your attention.